now being recorded.
So when you post the slides, Tricia, I'll begin.
Yes, I had them, and then
There we
then
go.
I didn't.
There we go. Great. Welcome, everyone. We've got about 50 people on as on-time arrivals for this webinar, and we're very happy to have you join us today. This is another in a series of webinars from the InCK Resource Network, and today we're going to be talking about listening to and learning from exemplary practices in child health champions, and how child health care transformation as both part of this crisis and an opportunity. We wanted to begin with a little bit, and thanks very much to Charles Bruner, who's the National Resource Coordinator and leader of the InCK project, with a set of positive experiences and resilience in a time of physical distancing, and to remind us all that children, families, and providers are all stepping up and responding as part of the COVID crisis, whether it's through rock art or street chalk or virtual visits or porch packs. The overview of our presentation today is that I'm just going to talk briefly about child health care transformation and the InCK's perspective. Then I'm going to give bright spots on exemplary child health practice adaptation and innovation, a report on our listening sessions. Then we're going to have reflections from champions in the field. Dr. Ben Danielson is the Senior Medical Director for the Odessa Brown Children's Clinic at Seattle Children's Hospital and the Janet and Jim Senegal Endowed Chair. The Odessa Brown Children's Clinic is a pediatric care center based in the heart of Seattle's Central District, where engaging and responding to families has been part of the mission since 1970. The Seattle Times says that with Dr. Danielson as medical director, Odessa Brown Children's Clinic connects patients to resources to tackle the roots of the health problem. Dr. Rob Kahn is a professor of pediatrics, the Associate Chair of Community Health, and Associate Director of General and Community Pediatrics at Cincinnati Children's Hospital Medical Center. Dr. Kahn has a strong interest in reducing child health disparities. His clinical practice focuses on serving low-income urban children, and his research focuses on understanding the origin of child health disparities and developing community interventions to promote equity. He has a leadership role in the Population Health Initiative, focusing on reducing child morbidity and mortality and ensuring children thrive. Dr. Risa Bradeen is the Chief Medical Officer at Metropolitan Pediatrics in Oregon. Dr. Bradeen is highly regarded in the community for her excellent and compassionate care for children, particularly those with special needs and developmental challenges. She previously served as Chief Medical Officer for Family Care, one of Oregon's first care coordination organizations. She's cared for children in Oregon for more than 2 decades as a primary care pediatrician. Dr. Seiji Hayashi is the Chief Transformation Officer and Medical Director for Mary's Center, a community health center that provides health care, family literacy, and social services in the Washington, D.C. metro area. Dr. Hayashi is an experienced leader in primary care, quality improvement, and health policy at the local and national levels, including his role as the Chief Medical Officer for the Bureau of Primary Care at the Health Resources and Services Administration, HRSA. He's also spent a decade in academic teaching and conducting research at Georgetown University and at George Washington University. And last but not least, InCK's resource manager, Charles Bruner, is going to talk about Carpe Diem, from ingenuity to transformation. So again, I'm going to talk about the listening sessions and learning from exemplary practices and child health leaders. As a reminder, you will receive a link to the recording and a copy of the slides after this, and we are really delighted to have all of you join us. We begin from the point of view that child health is not just the absence of disease, but a state of physical, mental, intellectual, social, and emotional well-being, and that children live in their families and environments and communities. And that comes from the WHO definition of child health. Before COVID-19 emergency, the mission of InCK was to support leaders in the field in advancing child health care transformation. and it's consistent with our funder, the Robert Wood Johnson Foundation's initiative to build a culture of health framework. We've acted to produce and disseminate state-of-the-field resources based on Child Healthcare Transformation Framework developed in partnership by our National Advisory Team, whose names you can see there. I'm pleased to be the National Advisory Committee Chair and with Maxine Hayes as the Vice Chair, and then to share resources and expertise to advance the work of the National Resource Partners, who include more than 25 national organizations. The framework for child health transformation that InCK uses is shown in this Venn diagram, and it talks about practice transformation with the high-performing medical home focusing on primary, preventive, and promotive services that partners with families and is connected to other services. That it has metrics and measurement tools advancing that transformation, that the financing reflects the value of that high-performing medical home over existing practice with payments and incentives aligned, and the culture transformation that it's going to take to emphasize healthy development, looking at relational empowerment and a health equity perspective in all of the work that goes on in those practices. We often talk about this high-performing medical home. You see there the design for that, and that includes restructuring and enhancing office practice, particularly well-child visits, so that they are focused on family engagement, guidance and parent support, and augmentation such as Reach Out and Read, incorporating relational care coordination, not just the minimal care coordination that's in every medical home, but going into more intensity and having support staff to do that, and linking to other services, whether they're embedded in the medical home, like Healthy Start or Dulce, or whether it's integrated behavioral health or linking to home visiting, early childhood mental health, and other services. We know that there are innovators who are transforming practices, and the people you're going to hear from today and all of the people on our listening sessions are a part of that world. So we're going to talk now about child health care transformation in the COVID-19 crisis. The context in which we're undertaking this focus is one I suspect is familiar to everybody on the webinar listening today. While the greatest medical impacts are among the elderly and the infirm, the long-term social and developmental impacts are greatest for children. COVID-19 has certain and uncertain concerns for children's health. They may be less likely to get it, or maybe they're going to get multi-system inflammatory syndrome and end up with something really serious happening in their health, in terms of their health. It's disrupted the lives of virtually all children and families with greater exposure to stress and adversity, and attenuating their opportunities for social, relational, and educational support. It's added to the stress of parents with them taking on additional responsibilities for care and nurturing. It has had very profound impact on the 1/4 of children already at greatest risk, particularly children of color and poor children. It's disrupted primary care and well-child visits, and it's at the same time created an opportunity to change. Our focus begins based on the guidance from the American Academy of Pediatrics, which is linked in this slide, and they talk about adhering to bright futures and recalling those who miss visits, thinking about physical distance, whether that's separation by location, space, or schedule, or using virtual visits, and of course protecting staff, thinking about certain medical care priorities, particularly for the youngest children, immunization, newborn screening, and breastfeeding, and having social and emotional priorities dealt with to provide support for the emotional well-being of families in this stressful time and to help address concrete needs and partnerships. And we're going to hear today again about how these exemplary practices are doing all of those things. We convened 2 virtual learning sessions on May 4th and May 11th to gather insight from practitioners who have led innovations to advance child health transformation, about what they're doing, about what are their innovations, about how what they're doing can inform the future, and what they think we need to be doing going forward. I'm not going to read this list, but the participants for the listening session, to whom we're extremely grateful for their time, all of them are very busy in their practices, worried about families, worried about staff, worried about communities in which they live. But we had a mix here of people who are delivering pediatric primary care every day on the front line to families, and those who are trying to run and guide the systems in which those frontline providers deliver services. In some cases, from some of these places, we had people, two people, one each doing those things, and sometimes it's the same person doing those things. So the questions that we asked in the listening session were about how the crisis had affected delivery of primary care, particularly well child visits, about whether they'd been able to conduct some well child visits virtually, about whether their visits were being reimbursed by Medicaid, about their experience of the virtual contacts with families and what was working well and what was not, about the actions and innovations they'd undertaken to support families, particularly during this time of sheltering in place or physical distancing, and whether or not they had care coordination support filling a role in the aspect of this care. We asked them whether they'd been able to provide guidance, emergency resources, or materials to families and how that was going, and what they thought ought to be incorporated into their primary and preventive care after the pandemic had ended. So these are our frontline sheroes and heroes in times of crisis. This is not from one of our practices, but it's one of those great photos, this one from Hudson County, New York, sending us the message about what frontline providers really want us to do. The three headline messages we heard in our listening sessions were about the need to rapidly pivot, to ramp up, and to do the right thing in the context of responding to families. So in terms of the rapid pivot, that was really about making the structural changes in medical care that had to be made during the COVID-19 emergency. We heard them say it was all hands on deck to respond in a matter of days. They told us we used every possible way to make it clean and safe. So one task they had was to sanitize and separate, and particularly creating separate times for well child and sick visits, or dividing staff, or using a tent, and making sure that everyone had PPE, staff and families. About prioritizing and rescheduling. Prioritizing, as the Academy of Pediatrics recommends, those visits for infants and toddlers under age 2 to get those immunizations done, to make recall contacts to those who are missing appointments or are overdue, rescheduling non-urgent visits, and using things like their immunization or newborn screening lists to identify those youngest children who needed visits now. They were doing reach out and check-in work, checking in about immediate medical needs, particularly for those who had chronic conditions, and having people review their patient lists and identify those they were worried about. Using care coordination staff to do check-in chats with families, responding when there is an infection in the family. They were trying to build welcoming trust, using greetings at the door, not with someone in a uniform, but somebody who was a welcoming staff to help do the COVID risk assessment or take a temperature, to post signs, to start with a call or a video contact before a face-to-face visit, to offer mental health support immediately by phone or on site, and to make COVID-19 testing available. In the context of virtual visits, there was this incredible ramping up. People told us 70% of sick kids were determined not to need to be seen in the office. And we went from 5,000 virtual visits per year to 5,000 virtual visits per week. So the first task was about retraining and retooling, retraining staff. How are you going to do virtual visits? What are the scripts? Which staff are going to do it? Are we going to move staff from specialty to primary care? How does the workflow need to be reorganized? Are we going to start with visits by telephone? Are we ever going to go beyond visits with telephone? What do we have to buy in terms of getting this to work? And how are we going to use our electronic health record or not be able to use it? Talking about reality versus the virtual world, but people really recognize the challenges related to the digital divide, particularly for the families they serve, but also sometimes for staff. They were surveying what families needed to engage in virtual visits and helping families use the telephone or internet tools or buy minutes and so on. Many providers and families like this method, but many feel the distance and don't really like it. They had web platforms that didn't perform well for them on the patient and the practice side, and they saw the challenges of screening virtually while protecting confidentiality. They're using the whole medical home team, a whole virtual team. Schedulers, nurses, physicians, care coordinators, community health workers, medical assistants, mental health providers, family specialists, and others were all identified. redeploying staff to connect with families and support them, holding virtual team meetings, and as I mentioned, accelerated the delivery and integration of behavioral health, including virtually. And they really were focusing on families, recognizing that not all families wanted somebody to be able to look into their home, not all wanted to or were able to respond because others were present, and not all had the trust to engage in virtual visits. All of the people we talked to were keeping equity and cultural competence at top of mind and using strengths-based, family-centered, and community-based approaches in virtual visits and all visits. And our third area, thinking about action to support family well-being, we just called it Do the Right Thing. And Dr. Danielson, I think, actually said that during the listening session. It's not about what your professional agenda is to accomplish, but rather responding to and supporting the family, told another participant. So first of all, defining family support as a priority, thinking about high-tech resources to support high-tech contacts, making it the organizational priority to address families' non-medical needs and training staff about how to do that, connecting with families and giving attention to the social, emotional, and mental needs while being strengths-based, delivering information virtually, through the mail, through drop-off packages, boosting the cultural competency of their practice with interpreters, peer-to-peer family support, community health workers, and others, and using virtual video and other tools to do relationship building and coaching with families. They're connecting with their partners, that whole array of food, housing, medical, legal, and working with private companies to get donations, working with culturally oriented and diverse community groups, using Help Me Go and other community structures to help make connections, including accountable care structures, and working to scale. One project, Reach, contacted 14,000 patients by phone to identify needs in a matter of weeks. And then they dropped off or mailed food, supplies, medicines, and more. Others emailed all of their families for the first time, offering concrete support for basic needs. Others are coordinating food brigades and phone brigades to connect families with food, diapers, supplies, mattresses, toys, books, and more. We heard providers' concerns about families, about social isolation for overburdened and under-resourced families who lack financial and/or social supports. We heard about the concern related to child abuse and neglect, missed reports, or not being able to put their eyes on the child. We heard worries about health and development because of missed visits or missed immunizations or newborn screening follow-up, and gaps that might occur because guidance, screening, and support for development were not underway, and that might be true all the way from infants to adolescents. We heard concerns about the social and economic impact of COVID-19 on families, deepening the social determinants of health, poverty, racism, inadequate and crowded housing, and families' basic and concrete needs for food, medicine, diapers, thermometers, and other basic supplies, and the concerns about the digital divide, helping families who lacked internet service or mobile phone minutes, and helping families use the technology they may have. We heard concerns about how to stay in business as a pediatric provider in this time. The staff needed new schools for virtual care, how to do the visits, both visits and care coordination virtually, how to ask, listen, and respond to family concerns and needs, and how to work as a virtual team throughout the whole care process. We heard that pediatrics is a volume business and that the volume for this group was 60% at best and more like 30% in some of the practices and clinics, and that furloughs and layoffs have already begun in their organizations or their practices. And then the problems with payments. 30 years ago, some leaders of the American Academy of Pediatrics coined the term in testimony to Congress about no pay, low pay, and slow pay for Medicaid. And we know that not all state Medicaid agencies are paying the same rate for virtual as face-to-face visits, despite encouragement from the Federal Centers for Medicaid and Medicare Services. Not all states quickly opened up codes for virtual visits, and where payments are available, Medicaid and other plans are not paying promptly for the pediatric visits. And they're concerned that societal challenges are exacerbated, that the issues facing their families are exacerbated, that not all families are safer at home, that societal weaknesses such as racism have worsened in this crisis and increased mistrust and suspicions about bias. and that they need to carry forward their focus on equity, social determinants, and community partnerships. And while they're doing everything they can to address the families' needs and social determinants, that many of these approaches are not viable without sustainable and adequate funding. That they're looking back to post-COVID-19, looking forward to post-COVID-19 practice, that there's no going back to normal, that telehealth is not going away and will remain a business model, that the horizon for the use of technology expanded. At the same time, some practices and clinics are not going to survive. They told us that this pushes the whole field forward in terms of population health and I think community health and systems work. Much of the innovation has been about partnerships, as we learned, and this time has demonstrated that current funding structures do not support transformed practice. We don't know what the model is going forward, but it's clear that a fee-for-service approach is not going to get us there. So let me now turn it over to Dr. Ben Danielson to give us some of his reflections from Seattle.
Thank you, and I'm really honored to be part of this conversation today. Just many of the practices and people I admire in primary care are on this call, so excuse me if I get a little bit verklempt. I'm here with Happy, one of the site clinic directors, and we've just shared a couple of our thoughts on what kinds of innovation we've been working on implementing or have implemented here in the clinic. Happy, do you want to start off?
Yeah, and so as we talked about increasing our telehealth visits, we, again, as you said earlier, realized the digital divide, and we were able to utilize a grant from the Washington State Healthcare Authority to obtain phones from Verizon to give out to our families with minutes and unlimited data. And so that also, that helped us kind of give families some way to contact us. We also created kiosks at strategic places around the community for families to go to also utilize our telehealth visits. But again, kind of building off what you said earlier, not all families are trusting of virtual visits. Not all families are comfortable with virtual visits, and so the ramp up is slower than some of our funders are wanting. And so, you know, it's really trying to make that argument about, you know, building trust in our community in order to serve their needs appropriately.
Our innovation thinking has gone across the spectrum of our clinic, and sometimes innovation looks different in different ways. When it comes to supporting our staff, I think I mentioned we sort of have a daily telenovela sort of model of a show called Day by Day that we project out to all of our staff because they're so far flung, which sort of mixes some snarkiness and bad jokes from me with some of the more sober topics that we have to address as well. We've really also integrated mindfulness and yoga into our daily sessions with staff so that they can virtually participate in these activities and kind of pay a little more attention to reflective practices and thinking about their own needs. There's also this innovation of decision-making because what we've noticed for big organizations, small organizations, governments, that decision-making has been really fast and really sweeping over the course of this pandemic. So one idea we developed together was the equity pause, where as a decision process is going along, what we've tried to practice ourselves and have recommended to others is this equity pause that kind of mirrors what happens in an OR with that very successful sort of stop and do the checklist thing in order to promote safety. In our case, this pause asks you to take a breath and then really reflect on three key equity questions, three or four, sorry, that help you contextualize your decision-making and maybe might help you avoid those unintended consequences that can show up when big, fast decisions are made that could really negatively impact communities of color, low-income communities, and those things. We've used our virtual resources to keep developing programs that we were working on before. So now our Birth to Five program that is led by parents themselves will be going to a virtual format, and ideas like that have been really important. But also the personal touch of our nutritionists working with breastfeeding families has been a really important component. Really thought about those moments when a parent and a child are maybe away from their home, and when that might be an important part to be especially attentive to issues like domestic violence, where a person may not be able to talk about that when they're really kind of trapped and isolated in a home. We've also thought about this impending bow wave of oral health disease that is probably coming just because of the inability to provide regular dental care to a lot of kids. So we slap fluoride on any child with teeth who comes through our doors, and try to just use moments of contact to do as much good as possible. Our telehealth PCIT has been a really successful way for us to reach families that we actually had trouble reaching before, and other forms of mental health have been important. And our advocacy work has been especially important. We've been noticing flare-ups of clusters of COVID cases among foster care populations, and we've been sort of entering very directly into serving and supporting the community entities that provide care to the foster community. And we've seen the immersion of community health boards from communities themselves being advocates for their own needs and care, and we've been partnering with them. I know we have a short time, so I just wanted to rattle off a few quick examples and allow you to keep moving through this conversation. I want to say thank you to all these other clinics. I want to let you know that I visited about half of your clinics on the list when we were developing some of our own sort of future thinking programming, and you have all taught us so much about our work here in Seattle. So I just wanted to take a second to say thank you to all of you.
Well, thank you for sharing your remarkable work that's continuing there in Seattle at the Odessa Brown Children's Clinic. And if you don't know the story of Odessa Brown, I encourage people to go on and listen to that. We're taking some questions in the chat, but we're not going to answer them at this minute. Rob Kahn, it's on you.
Hi, thank you all very much. And I think what I'll do is echo the comment about partnerships and focus there. So our clinical practice serves 35,000 kids. We had the same drop in volume many of you did. We pivoted quickly to telehealth and other outreach. I think, though, I'll focus on 3 areas briefly around immunization gaps, around child maltreatment, and around social needs, and how we've been trying to address it truly from a community and population health standpoint. So on the vaccine piece, we've quickly tried to get our hands around just how far behind we are at this point. So we've tried to use quality improvement approaches to set up statistical process control charts to assess how quickly we can make up the gap and do some simulations looking forward. So really trying to get our hands around what could otherwise feel like a very chaotic moment. But I think more importantly on the vaccines, what's been exciting is real acceleration among the primary care systems in the city who serve Medicaid kids. There were 3 larger systems that collectively serve probably 80% of the kids, 90% of the kids on Medicaid in the city. And we've managed to come together in a series of collaboratives to adopt the same metrics around the immunization effort for the city. So our public health department, as an example, runs 5 clinics. The University of Cincinnati has a MedPeds clinic, and it's been exciting to see us come together with common purpose, thinking about improvement data and what we could learn from each other as quickly as possible in that catch-up effort. I think the second area I mentioned is child maltreatment. As was mentioned earlier, the drop in reporting has been substantial. And we pretty early on, we got a call going with the Cincinnati Public Schools and the County Child Welfare Service leads, and collectively realized when we don't have enough eyes on kids, is there an opportunity for the 3 large institutions to come together to better understand who we're not seeing and how we might jointly put together an effort to support families where they are. And so it's been exciting to see we have a series of initiatives coming out that'll be co-branded for the first time across the public schools, child welfare, and the Cincinnati Children's Hospital in support of families, both strengths-based messaging, but also supports for those who may have the need for public assistance for the first time and how to help them reduce the stress that they're facing. I think the third area is around social needs. We've had a longstanding partnership with the Legal Aid Society, partnership with the Free Store around hunger. But, you know, as much as there's an immunization gap, we've tried to crystallize with the same level of measurement the social needs gap. And so while we typically had 65 to 70 referrals per month to our legal aid partner, we've been down at 15 to 20 referrals per month, again, through telehealth. It's a lot tougher through those who hadn't come in. So we are trying to innovate in that space for the first time. We are using families' email. We found, for example, 250 prior referrals to legal aid, and we sent an email out to them saying, we know you've needed our help in our past. We're still hear from you. And amazingly, we had about a 60% open rate on our email, which I think is above typical industry standard for cold emails, and a number of families reaching out saying, I need help with rent assistance or unemployment and so on. So, but we've always sort of held phone numbers and emails sacred and separate from our care, and to me, it's a little bit like a step beyond the telehealth platform. How could we begin to think about a more continuous relationship with families that doesn't have to be encounters in the primary care or even telehealth encounters? The last piece of that social needs I'll mention is we have so many great organizations working on food insecurity in the city, but each of them is a bit of a silo, right? So if you have 15 or 20 groups doing meal delivery or running pantries, we've been able to work in partnership with the private sector and with these pantries to sort of develop a map of food insecurity for the city. And we've gotten to the point where we can now direct some of the larger agencies to areas of the city where we know there are vulnerable children, but don't have a pantry open or don't have a meal delivery site. So again, both in the vaccines, maltreatment, and social needs, sort of breaking down the traditional barriers between what is healthcare and what are some of the other health-related needs, and creating some exciting new partnerships. I think in a forward-looking way, we're trying to take that food map now and say, what would it take to have a trusted site within 1 mile, 1 walking distance mile of every low-income family in the city, so that as we move to more expanded testing, vaccines, mental health needs, there's a place for every family to get to easily as a first stop to then connect to primary care. I'll stop there.
Thank you so much, Dr. Khan. We appreciate you being on. Introduce Dr. Risa Bradeen. We'd like to hear about what's going on in Oregon. Dr. Bradeen, we're not hearing you. You're still there. You
okay.
Go.
Can you hear me now?
Yes.
Hi. So I'm Risa, and I'm the Chief Medical Officer at Metropolitan Peds. We're a large integrated practice with 50 providers, both pediatricians and nurse practitioners, behavioral health, nurse care managers. Serve about 40,000 kids. I think I can echo a lot. I was getting very jealous with the last presenter and with the network capability. We do have a network here that we've been working on with our Medicaid agencies that's really focused on early childhood, and we have many, many different key partners. And we're doing things like delivering some developmental boxes to kiddos and then working with one of the Help Me Grow programs. But we're not nearly as organized as what it sounds like Cincinnati's doing. One of the things that I think's been interesting is as we flipped on a dime to do telemedicine, so we had not implemented telemedicine before this, and then we quickly had all visits, including well visits, starting with telemedicine within a few weeks. And I think one of the interesting things was how it opened the providers' eyes, especially into the window of the homes of our patients, and really allowed, I think, the focus on social determinants to take a priority at a new level. And not that we weren't focused on that, but I think talking to families in their homes and looking at their situations, I saw providers being more willing to talk about food insecurity and kids pointed out lots of interesting things on the way to seeing their fish or their animals or their play set. That's been interesting. As far as just our practice, we have 6 sites, and so we implemented around the city of Portland. So we set up 4 of those sites to do well care and 2 to do more ill care, infectious disease care, what we call response sites. And we're still in that mode. As we've done all this, it requires a lot of rapid adaptation and things. With all that and all the adapting on the part of everybody in the organization and the patients, we still find, like everywhere else, that patients aren't coming in, and we've been doing a lot of outreach and we outreach to patients with chronic disease and asthma and ADD and any history of depression or seeing the mental health provider or anxiety. And we are still finding that if we engage in outreach and talk to the parents, families about how they're doing, that ends up developing a dialogue where they'll seek care. But we are definitely still seeing much more care prompted by our outreach than by people seeking care spontaneously. And with that, what's scary is that when we do the outreach, we find a lot of issues, lots of stressors, lots of challenges, lots of desire for more information. So that's been really different than our normal models where, yes, we have some outreach and reminders and things, but really in the old way, parents would seek care. So that's just given us a lot of pause and thought with that. 2 more things. I think from a private practice perspective, lately I think a lot about sustainability. We're a large practice, but as I watch this, I think I have concerns for all providers, but when you add those providers to people who own a small business, and then you add on all of the vicarious trauma and burnout and their own family stressors, that stress of that business and the financial challenges and the implications to their staff have been really challenging. And sometimes it feels a little overwhelming to get through that. Lately, what I've noticed, though, is people are getting through it, and with it, it's mainly, and I think we're going to talk about at the end of this presentation, it's turning that focus into that stepping forward and that resilience and what can you do to change and how are we going to reinvent ourselves and how can we be better when this is all over. I'll stop there.
Thank you so much, Dr. Berdine. Seiji?
Hi, this is Seiji Hayashi. I'm the Chief Transformation Officer for Mary Center. Mary Center is a federally qualified community health center that started about 30 years ago, caring for refugees from El Salvador fleeing the war. And since then, we've grown to serve about 55,000 individuals and about 20,000 children. And so that's sort of the backdrop. And we still serve about 2/3 of our patients are Latino immigrants, and we have a growing number of African immigrants into the DC area as well. And so overall, we're speaking 5 to 6 different languages every day, and in total, about 20 different languages are routinely spoken by our patients. So that's sort of the context of what we're trying to do. We've been doing telehealth in a limited capacity for the last 2 to 3 years, where we have medical assistants go out to families and then set up, do vitals and set up the video over the computer. And so we were relatively used to doing this, but this, we were only doing that for about 5%, 7% of our visits. And overnight, we sort of turned that around, and we were doing the vast majority of our visits virtually. We probably got that going in about 2 to 3 days, despite a lot of the chaos. I want to focus a little bit on sort of what it took to do that. And I echo what everybody else said, and all the things, most of the things that Dr. Bradeen talked about, we're also struggling with and dealing with. But the thing that the transformation piece that really helped us do the care that we needed to do was really around communications between providers and communications between providers and other staff. And Kay mentioned a lot of the different things that have been going on, across the country. But we now have a pretty well-oiled machine when it comes to scheduling, doing intake with the medical assistants, and additional work with our nurses, integrated behavioral health, warm handoffs to them, and social services, nutrition, health education. All this is done basically virtually from 9 to 10 different locations. And I think our ability to communicate with each other, we use Microsoft Teams to instant message everybody real time, and that has really helped us to make this whole process work. We are struggling with really doing the comprehensive preventive care. The well child checks. We can do the screening tools and the behavioral stuff and counseling, but really the things that require a physical exam, vitals, vision, all those things are we're struggling to figure out how do we do this, especially when families are scared to bring their children in. Even as we sort of separated out the high-risk respiratory clinic patients with the lower risk clinic patients. And that has been a major challenge. And we are devising plans right now to do over the summer campaigns to do back to school physicals where vaccines and whatnot are all done simultaneously, as well as having dedicated times set aside during the day to fast track families in getting them. So those are some of the major issues. And I don't know if others have mentioned this, but dental care and oral health screenings have really been a challenge. We have 4 sites within Mary Center that do dental care, but because we are only doing emergency dental work, the hygienists and the routine preventive visits are not being done. Sealants are not being applied, and we're very worried about that as we move forward. And so as states and municipalities begin to open up, we're really sort of focusing on that. Some of the major challenges you've already heard about, broadband access for our patients using, video calls is a major issue. Unemployment and food insecurity are things that, are really challenging for our entire community. And therefore, as we think about, moving forward, we really do need sort of advocacy, to make sure that payment for telehealth, televoice, televideo are reimbursed at a higher rate. We do need support for community broadband where people can really access the network. And then also really making sure that we can maintain that flexible access. Our patients many of them are working on the front lines, and we are calling them from their work, from their home, from the parks, from everywhere, from their cars, and enabling these access has been incredible and sometimes limiting, but you can do a lot. You can really do a lot, and we want to make sure that we can advocate on the policy level to make sure those things are, available to underserved communities such as ours. So those are some of the major highlights, and I'll stop there.
Thank you so much, Dr. Hayashi. I'm just going to mention again, if you have questions, we hope we're going to have time for a few, if you can put them in the chat. We've got a large group here, so we'll just manage questions and discussion through the chat. Before I turn it over to Charlie, I wanted just to mention and give thanks to our other listeners. So Charlie was a listener, I was a listener, Martha Davis and Allison Silk of the Robert Wood Johnson Foundation were listeners. David Willis, a senior fellow at the Center for the Study of Social Policy, was a listener, and Melissa Bailey from the Center for Healthcare Strategies was a listener, and they all contributed to the analysis, the qualitative analysis of our listening sessions that I presented to you earlier, and I should have had a slide acknowledging them, but we really appreciate those extra listeners. Charlie, carpe diem.
Well, thank you very much, Kay, and really thank you for the four presenters who gave reflections on what really the best of the best did to respond to this crisis and really advance work and really did those three things of that rapid pivoting that was so essential, ramping up to respond beyond what they'd been expected to respond to normally because families are facing extraordinary times, and really to doing the right thing, to doing it in a culture of health and response that recognize where families were and emphasize the relational health. So I really want to thank those four. And when Kay said that she was one of the listeners, Kay was the facilitator. She was the recruiter of all of the people who were on our listening sessions. And then she wrote up the qualitative analysis that we did that formed this and really was responsible for framing the work in terms of that rapid pivoting and scaling up and doing the right thing. And so really want to thank her for all of her leadership on this. She's been a partner with us, obviously, for the InCK's work. And as we said before, even before the start of the COVID crisis, we were pressing for child health care transformation, which I think could fairly simply be put moving from a medical care system to a healthcare system, moving beyond just the important side of using medical expertise to respond, vaccinate, and address child's physical health conditions, to promoting those aspects and doing relational health that is going to improve the status of child health care. And certainly all of our presenters were already doing it at the time of COVID. What does this hold for the future, and how can we respond and really continue to transform child health care, drawing from what we learned through the COVID-19 pandemic, and really why it is even more important in times of crises to respond in this holistic way than in normal times. So one of the quotes here is, never let a good crisis go to waste. We know that some prior primary care practices and clinics probably will not open, and older primary practitioners may retire. And given the current way we respond and finance our medical care system, which is fairly low reimbursement rates for primary care visits, which require them then to be short and directed toward just the basics as far as medical care, could hasten a trend toward less care unless we do something to really actively transform the system and learn from what we've done with COVID to move forward in the future. And I really think that transformation involves being in the right place at the right time with the right capacity, as Ann Mosley once said to me. And I do think that this healthcare transformation, we do have the right capacity. We know from the exemplary evidence-based practices that we can respond more holistically to families and young children, and that does improve health. And therefore, we can reopen primary care, and we can really reconstruct the care practice settings and resources and staffing and use of technology. And to do so ultimately requires attention to what is in our practice transformation framework. And so really, I think what we've learned and what we now have an opportunity as we move forward is advance to a better normal, and simplifying what the tremendous amount of activity has been underway and how practitioners gone above and beyond the call of duty. It really, I think, told us that we can strengthen practice capacity to engage families. And one thing is we can use high tech, we can use virtual office visits, we can use virtual peer support groups, we can use advances in getting information from parents online before they come and equip them for their visits. We can use technology to enhance relational and empathetic care. And that should be part of what we finance and support as we move forward. But we also have to make sure that we have that high touch. And all of our presenters and our listening sessions were very clear that while technology and virtual visits can do something, the essential thing is to have that relational care coordination as a core to team-based care, that we have to establish trust with families, we have to provide support to them, we have to identify what they want to do and then work with them. And this requires both the child health practitioner, be it a pediatrician or a family practitioner or a nurse practitioner or a physician assistant doing that work, but it also requires much more in the way of a team-based care with some care coordination and support, and that this has to be part of our financing. We really have to increase actionable and continuous communication. And I think we heard from the presenters that it's not just getting to every well child visit, but having something that parents and kids have continuous access to communication. We've got to create metrics that really do respond in a better way to their concerns about their children's health and development and equip them to be their parents, their child's first nurse and safety officer. And then we have to finance this high-tech and high-touch components of effective care together, which ultimately means fully supporting an office practice which is able to do much of what our presenters said. And we've got to have a financing system which recognizes that's high value, and it's a much higher value than what currently we are reimbursing for. So we've got to up those reimbursements. I also think what we've learned is we have to build and reserve capacity for emergency responses, and whether it's a flood or a hurricane or a pandemic or some other really disruptive community event, practitioners, particularly for young children, are often on the front line and with public health and maternal and child health are the points of contact for children and families. That's how you can get to them and ask them if they're all right. And we have to create within our disaster response systems much more in the way of funding and support. Our exemplary practices that were able to do something because they were really ingenious about securing additional resources or able to do something because of their settings, but not all practices can, so we have to do that. And we really have to establish that culture of health care for all kids and really create something where we are emphasizing that it is about responding to the child's physical and mental health needs, but it's also about responding to the child in the context of the family and ensuring that we're responding to support those developmental and behavioral and cognitive development needs, and we do so in the context of the family and community. I do think we've learned that there are a lot of things we can use to augment or accelerate and provide more continuous response by taking advantage of virtual activities and high-tech approaches and online resources and apps. And we're looking at some of the different things that some have already existed. For instance, online screening that really stresses family engagement in preparation for well child visits, as conducted through well visit planner cycle of engagement and the telehealth and well visits. But I think we can really build upon that. But in the end, what we have to make sure is that high tech and some type of virtual capacity is not a substitute for the practitioner and the practitioner's office really engaging families and helping parents be the best parents and nurses they can be for their kids. And I'm very heartened by what has happened during the pandemic, of what people have stepped up and done. And I think they've created a lot of innovations and ingenuity. And now it really is, I think, upon us to make use of that, not only today during the pandemic, but as we go forward. And one of the things we want to commit to do is work with all of you, and any way we can, that we can achieve collective impact and really advance child healthcare transformation and child healthcare, not just medical care, if we do build upon what we are learning and engage in collective advocacy. We're going to have continuing webinars and working papers. We've done some short takes on COVID-19, and as Kay said, we're going to make both the slides here available and the recording on our website. So I want to really turn it back over to Kay now, and I knew this was going to be a jam-packed agenda, but we want to follow up with you, and please do use the chat box if you have other questions, and we want to move forward together.
So I think we might be able to get through two questions. Dr. Danielson, people wanted to hear those equity pause questions. Can you tell us what those are? Or should we just send that out?
I can tell you what they are really quickly. The 4 questions we try to use are, what are we assuming about people's needs or capabilities when we're making a decision? Number 2, is this decision informed by the communities we serve, especially if they're low income or communities of color? The 3rd is, does this decision promote differential or unfair distribution of resources or services? And the 4th is, what are the potential unintended consequences of this decision? They're designed just to create conversation and put a little pause into a decision, and it's come in handy in some of our state discussions around remdesivir distribution in the last week or so, and happy at another example with the hospital.
And so I introduced this to several different management groups at the hospital and executive decision makers, and they have also adopted this for decision making. And so any large decision that's happening at least in the nurse practitioner and level for those senior management decisions, they are implementing this at the end of their meetings.
So I'm going to put you all on the spot, and I'd like to start with Sejay and just say, could you give us in a word or two the thing you most want to carry forward?
Was that for me?
Yes, just starting with you. Others.
Okay. The things that I do want to carry forward is this notion of flexible access. And I think that using virtual or telehealth services, I think it makes a world of difference for busy families and parents, and if we can somehow get financing and payment for them commensurate, I think it would really be great.
Rob, Tom, what's the one thing you want to take forward, top priority?
Making sure financing shifts to support the kind of networked population health effort we're putting forward here.
Great. Risa Burdine?
I think maybe thinking about how we use our whole team in transforming how we deliver care. As financing shifts, how do we really use all of the resources at our disposal and then the broader network outside of our offices?
We're going to go 2 minutes over. Dr. Danielson, what's the one thing you want to carry forward?
Just about the wellness of your teams. You cannot do this work without having teams feel supported, safe, and empowered to make good decisions.
Thanks to all of you. Thanks for all of the folks who were listening today, and all the people who participated in our listening session, particularly to our 4 presenters today. we'll look forward to seeing you, hearing you, learning from you in the future. We're adjourned.